I'm one of the PGY3 residents. Thank you to Dr. Cohen, as usual, for providing this very interesting case. It is a pretty quick one. So we'll get started. We have an 83-year-old female with blurred vision in the right eye. She had started Lucentis therapy in 2012, about 10 years ago, and her left eye is doing okay. She does have some systemic conditions, hypertension, just hypertension, and then she had received her flu shot. No surgical history, and she's only on amlodipine for her medication. For visual acuity, her right eye was 21/25 -1, and her left eye visual acuity was relatively normal at 20/25, and pressures were normal. OU.
Oh, yeah, this is kind of a fun one.
Okay, so we have a color fundus photo of the right eye. Media looks clear. Nerve looks flat. Vessels look pretty unremarkable. In the macula, especially in the fovea, there's a mottled, light-colored lesion, I guess, with some pigment inferiorly as well.
Good.
Here as well.
Then we have an OCT, I guess, of the same area. Looks like there's a pretty prominent serous PED, and then some subretinal fluid with some hyper, what would you use, reflective lesion, specks in the outer retina layers.
We have intraretinal hyperreflective dots.
Intraretinal hyperreflective dots.
Yeah, nice. So there's a lot of images in here that kind of runs the cuts of the OCT. So I'm gonna go through that kind of quickly and then we'll go back. Okay, so
Put that there. Yeah, it's like casting runes.
there we go. I'll go back now. And you can make comments as I go through as well.
Okay, it looks like there's in the serous part of the PED, there's like crystals or some kind of hyperreflective material in there.
Yeah. Nice. And then possibly there temporally as well. So
Oh, yeah.
Oh yeah.
it's right overlying this area right here. So it's very bright yellow on this photo. Okay.
That's all case. Nice.
I think those crystals kind of give you a hint at the diagnosis, but I don't remember what it is off the top of my head. But in terms of differential, we talked about CSCR. You can get PEDs with macular degeneration. Maybe some other causes too.
So I just summarized the findings here. The color fundus photo has shown soft drusen and possibly refractile exudates. Those were those bright yellow spots that when we went over with the OCT, it had those hyperreflective layers. So PEDs with some with hyperreflective layering, intraretinal RP migration or interretinal hyperreflective dots. Yeah. Subretinal fluid, neovascular membrane, and possibly heme. Differential, so you covered some of these generation because we did have that subretinal fluid, central serous, polypoidal, RAP could be, and then I also put adult onset but vitelliform macular dystrophy on there, although lowest on the list. So the diagnosis for this patient was exudative macular degeneration, especially in the setting of her like anti-VEGF therapy kind of gives you a hint. And so this discussion is more about PEDs. So it's an interesting discussion. The pathophysiology involves obviously the RP is a monolayer of cells attached to the photoreceptors apically and the Bruch's membrane on the basal surface. I made put a little picture of here to kind of give that depiction. And so the these layers have to be pretty well posed to maintain retinal function. And once these are separated, that function is compromised. So it occurs when the basal lamina of the RP separates from Bruch's. And just to remember the layers of Bruch's membrane, so intercollagenous layer is the one that interfaces with the basal membrane of RPE. And then that detached cavity may contain exudate, blood, drusenoid material, and neovascular tissue. So there are a lot of hypotheses around how this occurs, and some of the more common ones are just age-related deposition of lipids, triglycerides, fatty acids in the Bruch's membrane, essentially thickens the membrane and changes its permeability. So that fluid accumulates and doesn't really drain out and develops into a PED. Drusen there can also disrupt fluid outflow through Bruch's. And then blood-retinal barrier breakdown can happen due to choroidal inflammation, which increases vascular permeability, or ischemic processes, which cause endovascular damage of choroidal and retinal vessels. So different types of PEDs. I found this really nice slide of different types that I wanted to show because it makes things a lot easier. So they're categorized under non-vascular PEDs and vascularized PEDs. Under non-vascularized, we have drusenoid and we have serous. So drusenoid PEDs are usually a manifestation of dry AMD, and they typically develop as a coalescence of larger drusen. They look like RPE elevations over like a homogeneous, mildly hyperreflective interior space. And then the serous PEDs have a dome-like RPE elevation with a hyporeflective space inside, and these are most common in dry AMD with CSPR. So we have the AMD, this photo is from a patient that had AMD, and this photo is from a patient that had central serous. And then moving over to the vascularized PEDs, so vascularized or fibrovascular PEDs usually appear as irregular elevations of the RPE, and the interior has this hypo reflective layering. The image depicts PEDs in type 1 and type 3 NV. So remember, type 1 CNV is below the RPE, and it's the most frequent form of CNV in exudative AMD. And then type 2, which is located above the RPE, is usually not associated with a PED, but in some cases you can have like a combination of type 1 and type 2 NV. And then type 3 is characterized by intraretinal vascularization that can be associated with a vascularized PED in about 86 to 93% of cases I found, and these are known as RAF lesions. And then the last photo they have here is from polypoidal choroidal vasculopathy, which is so you can also see vascularized PEDs of that. And then something to note is that drusenoid and serous PEDs are usually avascular, but they could be associated with like an underlying type 1 CNV. So this is a really interesting image because it puts so many imaging modalities together into one. This top photo here is a fundus photo, color fundus photo showing clean, extensive exudation, the retinal fluid and drusen. And then on the late FA here, you can see a pretty well circumscribed membrane that is showing leakage. And then on the OCT here, there's subretinal fluid associated with a fibrovascular appearing PED. And then the OCTA, these last two images are from the OCTA. And with the OCTA, you can see the blood vessels.
I hope the owl.
So OCTA is OCT angiography, and it's a non-invasive method of assessing these vascular layers. And so looking here through this cross section, you can see that there's actually vascularization inside the PED, which is not supposed to be there. So that kind of gives clue that, or that is an indication that's a vascularized PED. And then here as well, apparently these neovascular membranes light up this way on OCTA, which is, I feel very convenient.
It's nice.
So this is the interesting finding here was the multi-layered PED, also known as the onion skin. This is an OCT finding of organized layers of hyperreflective bands in the subretinal epithelial space, and these were hypothesized to be cholesterol crystals. So Grant, you got it, like we hit the nail on the head. Like they call it cholesterol crystals. Atherosclerotic coronary artifacts actually look very similar to this on OCT. So that was an interesting point that I found. And it's been observed, and I read a lot of papers, some that Dr. Cohen had sent me, and it's interesting, it's been observed in both non-neovascular and neovascular AMD, and then also in anti-VEGF treated and treatment naive eyes. So at first it was thought that these cholesterol crystals occur because of chronic exudation, and the longer that fluid sits around, the more likely of developing these crystals. And so if you're not treating exudative AMD, that fluid doesn't sit around for a very long time, it just scars over, and that's kind of the end of it. But then, so it was proposed that treated eyes typically have this exudation hanging out a lot longer, and they develop these cholesterol crystals. But then it was found that it was also found in non-treated eyes. So, unclear, but it could also be that there's subclinical focal neovascularization associated with these that's not seen on FA and ICG. In the non-NV AMD eyes that they had found. So even though they were calling it non-neovascularization, non-exudative AMD, it's possible that the patients might have had like a subclinical focal NV because they went based off of the FA and ICG findings. And one of the, I guess, larger scale studies that I saw, which aren't very many, but they found that it was visible in about 5 to 7% of neovascular AMD eyes, which they had an N of 230. So prognosis for pigment epithelial detachments, drusenoids, PEDs usually have the best visual prognosis, and then of course the location is important. So if you have a subfoveal PED, patients tend to have worse visual outcomes than extrafoveal. And then the other thing about PEDs is to really watch out for these and trend them over time, because long-standing PEDs are associated with development of choroidal neovascularization, and that's important to diagnose and exclude the presence of CNVs. Obviously, early detection is crucial in guiding therapy. That's it.
It's very good stuff. Nice. Actually, all of this. Yeah. Sam, do you mind? I'm gonna have Oliver go next. He's on an outside case.
Sounds
So
good.
if you have a patient with just a non-center involving PED,